I'm Congressman Andy Biggs from Arizona's 5th Congressional District. I am happy that you join us this evening. We have two prominent physicians who are here. Our purpose tonight is to talk about the science and data of where we are with regard to the COVID-19 virus and where we should go, where the science and data tells us we should go in the future. So I am really happy that you join us. I'm really happy to have these two wonderful guests who I've come to know Dr. Erickson just a little bit, talked to him a couple of times and watched his presentation. I'm very impressed by his reliance on data and science in order to form his opinions on what should happen in the country. And I am pleased to tell you that I've known Dr. Yasser for a long time. He's a good friend as well. And he also is taking a real scientific-based approach to the COVID-19. So I'm going to tell you a little bit about Dr. Erickson. He is a DO, an emergency medicine specialist. He's in Bakersfield, California, and has been practicing for 16 years. He has 7 medical facilities throughout California. He graduated from Western University of Health Sciences, College of Osteopathic Medicine of the Pacific, Western University of Health Sciences in 2004, and specializes in emergency medicine. He's also done an allopathic residency and has done ER work before establishing his 7 medical facilities around California. Dr. Zuhdi Yasser is president of the Yasser Center for Comprehensive Care. He's been in private practice in internal medicine for more than 20 years in Phoenix. He's a former U.S. Navy lieutenant commander in the Medical Corps. He is a past president for the Arizona Medical Association and a former member of the Maricopa County Board of Health from 2005 to 2010. He's a bioethics consultant for major hospitals with over 20 years experience. And welcome, gentlemen. Glad to have you with me tonight. Thanks for taking time to do this.
Thank you.
Thank you.
So the format for those joining us is we're going to have opening statements. First, we're going to go with Dr. Erickson and followed by Dr. Yasser, and then we will have some interaction and conversation between the two of them with me, trying not to be a speed stick to the high level of conversation that I anticipate. So with that, Dr. Erickson, it's all to you.
Well, I think it's important that we go back to the beginning and talk about policy. For instance, in the United States, we watched the Wuhan virus start. We watched a lot of disease progression. We watched fast movement. And we said, how do we handle this virus? What do we do? The decision was made to indeed shelter in place and socially isolate. And was that the best decision? We didn't know. So I followed the protocol. I said, okay, I took masks home to my family. I wore them in stores. I had tons of PPE. My staff is wearing goggles and gloves and gowns, and we're following this protocol to a T. We started doing testing, PCR testing, which is the nasopharyngeal swab. I waited for 2 months. Initially, my data was focused on what the CDC recommended, which was fever, cough, shortness of breath. So we were isolating those cases and testing them. Then they lifted that, and I had businesses calling saying, hey, I had one guy in the warehouse with fever. Can you test 300? So we had no symptoms coming in. Our sample started to get randomized at that point. And after about 2 months, I had about 5,213 total cases of the nasal pharyngeal swab. 340 were positive, which is 6.5%. At that point, I called a little tiny press conference, and I said, hey, do you guys want to know my data? I want to be transparent. I'm doing probably 50 to 60% of the testing in Kern County, which has about 1 million people. They said, sure. We did a little live press conference, and lo and behold, it started ping-ponging around. I didn't know it was live, for one. I found that out later. They ping-ponged it around, 10 million views on Facebook, 5 million on YouTube. And we started saying, man, this resonated with people. We're feeling that a lot of things we started seeing were, people are locked in at their homes. They're depressed. They're calling me for alprazolam. They're starting to drink at home. We started to see all these secondary, what I'm calling collateral damage happening. So I thought it was important that we get together and take a look at our policies and say, before we do a shelter in place, before we do social isolation, I think it's important that the science be there, because the collateral damage now is significant. As I'm weighing both collateral damage and the virus itself damage and saying, I think the collateral damage in the state of California far outweighs the actual virus. California is about 1,800 deaths today, and we have 40 million people. Every death is, of course, terrible. But again, the influenza also in 2017, 2018 had about 60,000 deaths. So some of the early models we saw were predicting 2 million, and that didn't exactly occur. So I say, okay, we took this policy, I followed it to a T. Now that we're seeing this sort of slower progression and lower death rate in California, what is the best way to move forward? And so I've read and studied the epidemiologists, and they've said, you know, the United States is really the guinea pig. And I'm reading the Swedish epidemiologist, Dr. Giesecke and Dr. Anders Tegnell, and they're saying, we didn't do that. And if you look at our numbers, you know, 200 deaths per million. The UK that's on full lockdown is at 385 per million. So they're saying, Dr. Tegnell specifically, an infectious disease state epidemiologist, said, we're very happy with our results. Our people are free. Our economy is not in free fall. We're happy with our numbers as far as, not happy, but they're saying our death rate is following what we would expect it to. And so my question is, can we learn something from the Swedes? Can we learn something from their model? And can we get our economy back on track to loosen this up so that we can get rid of some of the collateral damage of COVID-19?
Great. Thanks, Doctor. Appreciate that. And we'll go into some more of that in a second. Dr. Yasser.
Thank you, and I want to thank you, Congressman Biggs, for doing this, and Dr. Erickson. It's great to be with you on this panel, and thank you for your courage. And you know, if you had told me in March that it would be courageous for a prominent physician to have a contrarian point of view, to be in difference from some of the conventional wisdom, if you would, I would have said that's just sort of odd. That's not what is the tradition of medicine that I came from. And yet our government medical advisors, God bless them, you know, I was a Navy-trained doc. I trained at Bethesda Naval, and Dr. Fauci was one of our attendings. He's brilliant in what he does, but he's narrow in his advice. And for, you know, what we've done to America, as David Goodhill today reported, he said it's almost like giving hundreds of millions of Americans a toxin and assuming that somehow that is okay to do. And quarantine is something that has been applied specifically in certain areas, but not in such mass, unprecedented ways in which has been done now with this method that's been done. And I think we're bracing ourselves for a pandemic after the pandemic. And, you know, I have to tell you, as a frontline doc who has a small business, 18 employees, I'm doing primary care. I have had COVID patients that I'm diagnosing, treating, and doing telehealth with. I've seen my own practice have to metamorphosize into the current environment. So we're dealing with the PPE questions and all of this. So my opinions don't come from somebody who's sitting in an armchair and simply making guesses and recommendations. I'm on the front line. But, you know, in medicine, we've always had an antagonism between those who do, as we say, and those who teach. Those in the academic area and who are doing studies and want everything double-blinded and sort of sit down and pontificate, and those of us who are on the front lines. And we guess, and even our patients, they come to us, Congressman, and they tell us, you know, well, this oncologist told me this surgeon told me this, what do you think? And even with all the studies, there are those doctors who simply treat the disease, and the rest of us who advise our patients, and we treat the patient. And I think what's happening now is you're seeing our country treat the disease, treat the virus, but we're not treating our patients. And, you know, I have to tell you that the science is being looked at in a very myopic fashion. I don't care how much of an expert any of the people are that are advising our president and our Congress and our population. This is a novel virus. Influenza doesn't operate the way cold viruses do, doesn't operate the way hepatitis or other viruses do. Be they RNA, DNA. So we're still learning about what to do with this virus. And that's why every day the models are changing. And we said we wanted to, remember, they wanted to flatten the curve so that our healthcare system wasn't overwhelmed. And that healthcare system had to do with ICUs, and they showed us pictures from Italy. Even Italy itself was not Italy, in that there were parts of Italy that weren't overwhelmed and other parts that still are overwhelmed. And nobody really has a clear answer about what the reasons for that are. They're guessing about population risk, nursing facility issues, on and on. But yet to say somehow, and what I find the most difficult as a primary doc here in Phoenix, seeing so many diverse questions, is that we're not realizing this is not a one-size-fits-all approach. Arizona should approach it differently than California, than New York, than South Dakota. And yet it almost seems as if from CDC on down, if you didn't apply complete draconian measures, that somehow you were sacrificing other lives. And, David Goodall said it the best. He said, epidemiologists know viruses, but have no special expertise in agriculture, supply chains, labor markets, fiscal policy, social fabric, mental health. As Dr. Erickson said, education, family relations, national security, or any of the other areas of our patients' lives that have been disrupted while they simply approach the disease. So, I have to tell you, the fear and the approach to fear is what concerns me. And again, like I started at the beginning, I could never have imagined in March, just 6 weeks or before this, that America would be simply responding, number one, based on fear. I'm seeing patients say things about this virus that just belie reality, doing things as far as fear that is not what I saw post 9/11. And yet we're reacting as an entire nation in a way that has locked us down and is causing a pandemic that is going to cause, in a sonic boom way, a pandemic after the pandemic, as Dr. Erickson talked about collateral damages. And are we trading illnesses for other illnesses? And so many things I'm seeing now, patients staying at home that should get evaluated for chest pain, patients with cardiomyopathy that should have had their defibrillators put in, patients with hip replacements that are breaking them because they're at home and not getting them replaced. So many cancers that should have been biopsied that are being delayed 3 to 6 months, that now are going to have metastases and other issues that, by the way, are getting waivers from Governor's pen because of liability, which they probably need, obviously, because we don't have any choice. We can't force hospitals to do elective procedures when the governors are locking them down, and now they're just finally opening that up. So the problem is there's going to be all this sonic boom of illnesses that's going to happen over the next 3 to 12 months. People are going to say, well, we prevented this illness, and yet as a family, as a state, as a community, we never make one choice in a tunnel at the expense of all the other illnesses, from psychiatric to cancer to cardiac. So my 2 points I wanted to make first have to do with demagoguery. I can't believe my profession and this country has so much prevented debate, discourse, and discussion about what path we should take as a community, and simply focused myopically on the virus and these curves. And second, you can be a compassionate physician, a compassionate community, congressman and otherwise, and still believe that you disagree with a lockdown approach, and still believe that there are other lives out there that are affected in a way that is the most empathic way to look at this.
Well, thanks, Dr. Yesser. I want to throw some data that I saw today that I think is important, and it's basically a kind of a case fatality rate per million, and this is critical because we get a big number in the United States because we're a big country. We've got a lot of people. We also have done a lot of testing, more than any other nation by far. And so when you look at the death rates, you see Belgium has a per 1 million death rate somewhere around 640, Spain 510, Italy 453, the UK around 390, France around 350, Netherlands 265, Ireland about 240, Sweden 230, Switzerland right around 200, and the US around 185, 190 per million. That's our case fatality rate, and every one of those numbers represents a human life that we are all very concerned with, and we empathize with the families and those who are lost. But I think we have to put things in context, and look at the data and the science, which is why I wanted to talk with you guys tonight, both of you. And when we talk about it, you both mentioned collateral health issues, or what I would call secondary public health crises that are looming and waiting to happen. And I was just wondering, Dr. Erickson, if you would elaborate on that. And then Dr. Yasser, feel free. I want to facilitate a dialogue between the two of you on this particular topic. And so with that, Dr. Erickson.
Well, I'll talk to you about a doctor I talked to in Wisconsin he was an ER physician that just done a night shift. And I said, how did it go? And he said, well, like Dr. Jasser said, he said, I had a chest pain patient. It's been 3 days. I said, when did it start? He said, 3 days ago. He said, why did you wait? He said, I was afraid of COVID. So now he was having an MI, instead of getting treated immediately, he now has, damage to his heart that's progressive. Instead of getting the medications and treatment he needed, he waited. He also had some cases of abdominal pain that needed treatment right away, but the patient said, I was so afraid of COVID, I came in 3 days later, and now they have a much worse issue than before. These are two examples of hundreds across the country. My brother-in-law is an orthopedic surgeon in Texas, board certified, and he said he did a case about 3 weeks ago, and he got a letter from the board saying, if you do another case, you will be fined and possibly face 6 months in jail for replacing someone's hip and giving them the ability to walk. And I said, well, doctor, is your hospital overrun? He said, it's empty. ICU is empty. Surgical OR empty. So we've got furloughed doctors, furloughed nurses. We've got potentially a second wave, which is, we're all thinking we might get a second wave because we're sheltering in place. When we come out, it'll rise. And now we've got a medical institution with furloughed doctors and nurses. And I asked my CEOs in town, I said, how's your census? They said, incredibly low. I said, are you ready for a surge? They said, yes, we are. And then I looked on the computer to see how many COVID patients we had out of 4 hospitals, and it said 14.
Wow.
And yeah, and I think, if you just simply look at the rates of infection, some of the studies have shown that this is one of the things that we're learning about this virus is how quickly it spreads. So even there was a study out of Israel that was written that looked at the possibility that even the lockdowns haven't slowed down the contagious spread of this virus. So therefore, if you look at the asymptomatic rates are somewhere 50 to 60%. That was in your area, Dr. Erickson, that some of the studies you did, some of the studies we've seen in the Netherlands, in Sweden, in UK, they did random sampling. So my concern is now they're talking about immunity cards, which is not only unconstitutional, unethical. I would never sign one as an ethicist. Imagine if you're talking about diseases that could harm other people, then we should be concerned about alcoholics, drug addicts, all the psychiatric illnesses should carry cards. I mean, it is not only un-American, it is inhuman to think of such a thing. And yet, because of the fear factor, because of data that's being manipulated and misinterpreted, we're looking at all the asymptomatic people, the very few young people that have gotten ill. Why couldn't we have had simply patients that are 65 and above stay at home for a while, let the younger population? I'm not saying there aren't younger patients that have gotten very ill, ER doctors that have died that are young. Yes, there are cases out there. This virus, when it's in the wrong patient with the wrong genetics, whatever it might be, is deadlier than the flu. There's definite evidence of that. Nobody's denying that. But the aggregate data of the curves that this virus has shows that most patients are the mortality rate, as you're saying, is now bearing out to be less. America has demonstrated far more data than any country ever has. And yet most of the media is putting numbers up there as if somehow we have a quarter of the world's population's infection rate of coronavirus. And yet Syria and Russia show 4 cases, as if somehow that's valid data. It's not valid data in authoritarian countries, and we're thus confusing infection rates versus those that are measured and tested that were clinically biased. So the denominator's wrong, and the numerator, we actually don't know until we actually do random sampling and study it. So where the science is being confused because of the mass fear, and secondly, we're really missing a aggregate sort of trading of lives because of the mortality that's going to come from all of the diseases. As Dr. Erickson can tell you better than I'm in primary care. He does more urgent care stuff. But I can tell you that when you delay a lot of this, the aggregate lives affected in a population basis, 50% down in the ER visits doesn't mean that 3 months ago we had 50% just malingerers in the ER. That's not true. All those patients had real illness, appendicitis, bowel obstructions, pneumonias that should have been treated that are waiting too long. And nobody can deny that when you have 300 million Americans staying home, that somehow all those illnesses are going to add up to the thousands, a few thousands of critically ill people that are being affected in each state.
So both of you said something that kind of triggered in my mind. I wrote down just a little note. Two things. Hospitals furloughing personnel, ICU bed availability, ventilator availability. And I guess my question to you is, particularly in rural areas in Arizona, we've seen this. Those hospitals are in very deep fiscal distress because they can't treat what is deemed to be elective surgery, which is basically any kind of scheduled surgery, according to some of the definitions I've read. So the question is, what if you see these hospitals close or these medical facilities close in rural areas, what impact does that have on the public health system of our country?
Well, one thing I used to say is the worst way to help the public is to go broke. So when people say, oh, that hospital is just concerned about money, I say, well, if they're losing money and they go broke, how can they serve the community? So to give a short, pithy answer, that's what I would say. The second thing that I wanted to go over was just herd immunity. People hear this and they get confused by it. We use herd immunity every year. It's called cold and flu season. Once 70 to 80% of the people develop an IgM immune reaction that destroys the virus, it has nowhere else to go and it burns out. That is how you get rid of a virus. A vaccine takes you faster to herd immunity. The influenza vaccine helps us get faster to herd immunity and get over it quicker. Herd immunity is the only way to get rid of this virus. And so when people have told me that I'm dangerous for saying that, I say, well, Dr. Giesecke and Dr. Anders Tegnell have told me they are epidemiologists and infectious disease specialists, and they control an entire country. They have said that's the only way to get rid of this virus. And they've said in Sweden, we didn't do what you're doing. Our economy is not crushed, and we're doing well. And Sweden, as you know, has taken a lot of heat globally. People have said, you are reckless gunslingers. And I'm going, let's look at their numbers. 200 per million. Their people are working. Their children are in school. Their education is not being delayed. You know, they did some social distancing. They limited groups of more than 50. And the Swedes are smart. They separated and they protected their elderly and immune compromised. And they have large centers for their elderly. And I say to myself, their program to me makes sense. And then when I analyze the data with Dr. Witowski, who is a biostatistician in New York, brilliant, I've interviewed him 3 times, he said, there is no data for social distancing and sheltering in place. We did it because it was something to do when we were afraid when we watched China. But there's data for hand washing. We have great data for hand washing. But I think we took on a program that didn't have a lot of science to it. I tried it and I towed the line for 2 months. And then after I'd collected all my data, I looked at it, I said, you know, I think there's a better approach. And I think we've climbed up this ladder. And people have said to me, what's the answer? Oh, our lights went off. The answer is we need to come down this ladder stepwise. What does that mean? Open up the schools. Kids under 16, we need to let them go back to school and then see how our disease rate, our incidence, and our prevalence pick up, monitor it, then open up restaurants, monitor it. We can pull it back if we need to, but staying closed, elongating the curve, having immune systems decrease, spiking, and then having more death, to me, is not a good plan.
Dr. Yesser.
Yeah, and I think to add to that, very few viruses do we actually have cures for. We usually, as Dr. Erickson mentioned, We develop that herd immunity, and once enough of the population has either had it, been exposed, it won't spread as quickly because it doesn't have a vehicle, a human being to live in. So we're not defeating the virus. All we did by keeping people at home was delay the infection rate. And what that did was destroy our other defenses in our society, our strongest thing, which is our economics, the other healthcare, the other problems. Remember, the people that get sicker from this virus are those with other medical problems. The first thing that happened in my practice is the people that needed chronic care were staying at home, they were afraid, and they weren't getting that chronic care. To get back to your question, Congressman Biggs, about practice sustainability, not only are hospitals closing, but the Washington Post this time had it right last week. They had a front page piece about 47% of primary care practices in the United States that are on life support to start with, that are barely eking by in the past years because of Obamacare and all these other problems, because of our huge overhead, now may not survive by the end of the summer. Because, by the way, a lot of the help, I tried through the first round of the SBA loans. I'm now hopefully going to get it on the second try. But remember, our charges in medicine, our cash flow actually is 2 to 3 months behind. So we have yet to have this sonic boom also, because once our throughput goes down, my throughput in my office went down 30-40% overnight in the beginning of April. And once that happened, I had to start laying off employees. I had to decrease their hours. I was less able to be a frontline doctor, even though I still had a huge demand. And the same was happening in practices and specialist offices all over the city that is now going to have to somehow ramp up in a few months, but is going to cause a lot of patients to be backlogged like some countries are, because our system will not be able to have that capacity. And meanwhile, they would have lost their employees and unable to hire them, because the cash flow in 2 or 3 months is going to be so low, it's going to be what actually was the cash flow in April and May. So stand by. The practices that Americans have been so used to relying on, which is almost half of the American healthcare GDP is independent practices, are going to be really limping along, because the insurance companies, by the way, they've been helping us. They've been very open and trying to help out. But remember, they're still getting their premiums. Now, they're going to have a sonic boom in 6 to 12 months when the unemployment rate goes up and they're not going to be able to pay their premiums, et cetera. But patients were still paying their premiums. So insurance companies actually made more money in this gap because elective procedures were down and other things were down. But having said that, there's going to be a rolling pandemic after the pandemic as the American population gets sicker, because we had this all or none cataclysmic approach to this virus.
Yeah, so you're going to see this. The impacts, negative impacts, are going to be cascading in virtually every area of our economy for some time. And one of the ironic things that both of you kind of touched on as we got here is if you look at the data on our contracting GDP, you'll see that one of the leaders in that contraction is, ironically, the medical care sector. That sector is contracting far more than most. And that's because of the things that you've described there, where people aren't coming in. So when we first started this, we were told that the economy would open up when the curve was bent, right? When we would bend the curve, and then we'd be ready to go. My question is, from a lot of people, I hear that the curve has been bent. We've bent the curve, but we still don't want to open it up. What is, you alluded to a little bit, Dr. Erickson, Dr. Yasser, you as well. What is the next step as we go forward? If we wanted to make this societal recovery, because the reality is it's the whole society, that it's not just the economy, it's the society. We've talked about you're trading life for life, that type of thing. If we want to holistically help our society recover, what's the next step? What do we do? What does your data and science tell you?
Open up the schools. When I listened to Dr. Giesecke, 30 years as an epidemiologist, infectious disease, he's the chief epidemiologist of Sweden. He said, if I was in the United States, I would open up the schools immediately. I asked Dr. Witkowski, a biostatistician that's evaluated flu for 20 years. He said, open up the schools immediately. Kids do very well with the disease. And then monitor and see how incidence and prevalence occur of the disease. Look at the death rate. and then stepwise open up the economy. But to leave us closed like this, keep people in their homes, Americans and people around the world are social creatures. See, the thing is, I can go to Costco, I can go to Home Depot, but if I go to the beach, I have my hands in cuffs. And then we have prisoners we're concerned about in California releasing thousands, but if I go to a park, I'm on the ground with my hands behind my back. So you see, we're picking and choosing these businesses with not a lot of sense to it. So I can go to Costco and there can be 20 people in an aisle. We're all having a chat. But if I go sit in church for a while, that's a no-no. Right. So we need to stop this. Honestly, the American people have had enough. And my big message is this: herd immunity is going to happen whether you drag it out or not. It will win the day. It will be the champion. And that's how we'll get through this. Let's not drag it out through the summer. Let's get the herd immunity done. Let's get people back in school and back to work. I have too many people telling me, I don't have COVID, but now I'm bankrupt and losing my business. So let's get us back on track. Let's stop bickering about our First Amendment rights, as some have attacked mine, and let's get the country back on track. That's a stepwise approach that I think would work.
Yeah. Dr. Yes.
Yeah, and Congressman, I think what I would do is first have a more open debate about this publicly, so that those of us who have contrarian viewpoints from the so-called conventional wisdom are not shunned and criticized. I mean, on the one hand, they call us science deniers when in fact I have an allopathic MD. I've been steeped in medical ethics education, other things, and yet we should not do that. I think we could also call them scientists and others that are focused on one thing, and that's wrong to do that. Secondly, I think we should look at it backwards, which is, what are the highest risk? Definitely concerts, large stadium gatherings, entertainment parks, cruise ships, things like that need to definitely be put on hold until a longer time as we know more. But then the lower risk activities, regular businesses and office buildings, and from the legal professions to accounting to engineering to construction, all the things that we've shut down where you can pretty much do social distancing. And even restaurants can start opening back up because they can decrease some of the population until we know more. And I think quickly that'll ramp up. The higher risk things, nursing facilities, things that we know data has shown is very high risk, that's where we should have been putting all of our resources, how to prevent those deaths. You look at Mississippi, for example, they had a huge rate of mortality in extended care facilities. And I think it's because in some of these states we were focused, I mean, New York itself, they're claiming all this credit for what they did. And on the other hand, there's a lot of evidence that there were things that could have been done to protect patients in nursing facilities that wasn't done by the government because they were treating all the population as one, when in fact they should have looked more at high risk populations. So look at those segments that are high risk, save them and protect them, and let the rest of the population, children that show low risk, young people that are 50 and below, people without any chronic conditions, and get them back to work as quick as possible, open businesses, don't in a draconian way have the government tell us who can work. Americans know their risk, and they will fight this like we fight any other risk from a security perspective.
Well, I think Dr. Jasser makes a good point. I think I wanted to form like a physician COVID alliance for those of us that are actually working with this thing daily. I've seen thousands and thousands of COVID patients. I do PCR testing. I do serology testing. I'm watching for seroconversion of patients. So I'm right in the thick of all this. I've done about 6,500 tests to date, 450 some positives. I'm getting about a 7.3%. Again, moment in time. This is not data that's extrapolated. This is not peer reviewed. So what I'm saying is, why don't we, because this is a novel virus, a new virus, why don't we pool our resources, get together, instead of attacking each other's credibility, let's get together as a group and form an alliance and say, okay, Dr. Jasser, you're in Arizona. What do you see? Erickson, you're in California, New York. Let's make decisions county by county and say, okay, you guys are getting killed, and adjust our population based on what's happening locally. But if you have wide open hospitals and very little incidence and prevalence, let's open her up. And so I'm just thinking that I guess my role in having this platform is just getting the dialogue going and realizing the American people want to get this going. And we, I think on the front lines, have a real unique perspective to say, I believe they're right. The gestalt of the American citizen is often right. So I'm ready to move us forward. I'm happy to sit on any panels that have a stepwise, rational, scientifically based approach to open up the states.
And to add to that, what do we mean by risk aversion, right? So it almost seems as if it reminds me of a friend of mine who is an attorney, and no offense to attorneys, Congressman, but he said, imagine if the corporate attorney decided everything that you did in your business for policy. That would be, you would be paralyzed. You wouldn't do that much because the corporate attorney would tell you this liability, that liability. So most businesses then decide on a rational, reasoned approach for their business, their family, and with the legal advice. So right now, many doctors, we give advice, and yet we're sometimes risk averse because of medical legal issues, other things. So you're seeing right now the entire country paralyzed because of risk aversion from simply a myopic medical approach versus an entire community. And I think there are many of us doctors that are more rational in this approach that would balance these things and aren't as risk averse and are ready to take on a more balanced approach to this.
Well, I appreciate that. I think you're right. I'm with you 100%. I want to ask you about something that you both touched on. And that is when you start talking about herd immunity or population immunity, how widespread do you suppose the COVID virus actually is? I mean, it's almost impossible to tell because we don't have the capacity even to test all that. But how widespread could this be already?
Well, Dr. Giesecke in Sweden said that they think 25 to 30% of both Europe and Sweden are affected. And again, herd immunity is not going to happen until you probably reach 70 or 80%. So we got a little ways to go. The data out of China showed about a 1 month cycle from February 4th when it peaked. And China had the advantage of not knowing. They didn't tell their people to shelter in place until February 21st. So they had a couple weeks to develop this herd immunity. Now, some people are going to pick on China's data. I realize that. But the data we have shows that they did indeed develop herd immunity. You can look at their spike online on Wildermeter or CDC, wherever you want to go, and you can see a typical herd immunity. When you allow the virus to move at a rapid rate through the community, you get a spike in cases and it comes back down. Our cold and flu season is usually about 3 months, 3 to 4 months at most. So that's why I think people need to understand how herd immunity works. I've been watching, as Dr. Jasser has, he's probably younger than me. He looks better than I do. But we've been watching this cycle for 15, 16 years. And Dr. Giesecke said, he said, watching this coronavirus, it's like a severe flu. And these are epidemiologists that have been watching this for 30 years. So I'm going to defer to them. And I need to run. Unfortunately, there's another panel waiting for me, but I thank you guys for having me. I appreciate it.
Thanks, Dr. Erickson. We appreciate you being with us.
All right. Have a good night.
Yeah, thanks.
All right.
Dr. Jasser, you want to amplify that at all?
Yeah, I think, the herd immunity concept is so important that every year when people notice that one person at home gets sick and all of a sudden everybody else is sick, they've sort of been used to having viruses run through the house. And I can tell you 3 or 4 patients of mine that I've tested as COVID positive. They had a family member that came in from Europe or from Asia. And the one patient had a cough, had congestion, and had COVID-19. And basically the other 6 people in one family, nobody had symptoms. And I'm pretty sure they converted. I'm pretty sure they were exposed and developed immunity. So in our anecdotal responses, we're seeing that most people are converting, and the CDC correctly now is saying that the recommendations are anyone who wants to be tested should be tested, because that's really how you get that denominator, is what % are being infected. And to answer your question, some of the studies in random analysis in the UK, for example, in London, said somewhere between 30 and 50% of the population within 2 months was exposed to the virus and had positive antibodies in their early testing of random sampling. And that's what we should be doing in America, is not testing everybody, but doing random sampling. There's no country that's better in polling and figuring out whether it's Nielsen ratings or campaign polling. We can do polling in a way to test people and samples enough to know exactly what the infection rate is in America if it's done right, without having to test every one of the 350 plus million Americans.
Well, and Dr. Yasser, I'll tell you that one of the things that both of you kind of hit on tonight is basically isolating the most vulnerable population set. And in Arizona, I've talked recently to the folks who run assisted living facilities, and it would cost probably somewhere around $2 million to test every person who's in assisted living, either as a patient or the staff. And you could get 40,000 tests done and evaluated. I think that is so critical. And that seems to me like that would be a government priority, is to find out what's going on in that most vulnerable set as much as anything else.
It's like a war, Congressman. You have your SEAL teams, you have your battalions, and you have your advice that you get from admirals and generals, but then the civilian population decides where we should go to war, and then you get the right specialists to do it. Our battlefronts right now are in the nursing facilities. Yes, that's where we should put our resources and have our strongest fight, just like it is in our ICUs and elsewhere. But we've just shut down most of the military hospital units that were set up to do with all of the peak that was going to happen, which is a good thing, because it means not that many people got as sick as they thought were going to get. But it also tells you that we dumped a lot of resources into models that ended up being wrong, and also away from areas that probably could have helped some of the lives that we sort of lost in the mix of approaching everybody as one size fits all.
Well, as we get ready to wrap up, thanks to you for what you do. I know you speak out, and I know when we speak out on this, we take a position. We kind of sometimes receive the disapprobation of a certain group of the society. But I'm really, truly grateful to you for speaking out always. Your hard work, your focus on science-related remedies to these types of issues. And so I'm going to give you the last word. And just my question is, as always, and we've touched on a little bit, from here, where? From here, where?
From here to a reawakened America, back to our principles of what we remember them to be, that we're not simply myopic, to remember that, one of the reasons I went into medicine, Congressman Biggs, is because I want to care for the most and help the most patients possible. And every patient's life means the world to me. And just like my own family, if God forbid, one of our family members gets ill, we do our best to treat them, but we also don't forget about everybody else in our family. And that's the way you approach illness, is that, yes, when one person's sick, you do everything to make them healthier, but you don't forget about the rest of your family. And I hope we can go forward to get people healthy, to get them back economically working, so that they can keep their health insurance, they can keep their doctor and keep well, and keep our practices healthy so that we can take care of our patients. So thank you for being a voice of reason, Congressman Biggs, and for doing this, because it is bizarre to me, not only how risk averse it seems our culture has gone, which doesn't seem to be the America I know, but also how much free speech has shut down on this issue, and I just don't see it to be rational. So thank you for doing this. I appreciate it.
Yeah, thank you. And with that, I appreciate everybody who's joined us this night. And thanks, Dr. Yasser, and thanks to Dr. Erickson. And we may do this again soon.
Anytime.
God bless you, and God bless all the folks joining us tonight. Thank you.